Okay, thank you. I'm Neil Toft. I'm a plastic surgeon and I specialise in hand surgery. I work at Bishopswood, Clementine and Garden. First of all, I thought I'd run through the anatomy of the hand that's relevant and also how to examine the hand. You'll be glad to hear that it's much easier than the shoulder. I'd run through some common things you're likely to see in primary care, when to refer patients, and a few case scenarios that are hopefully relevant. So the best way to examine the hand really is just from medical school, look, feel and move. It's not as complex as the knee or hip. And I'll just run through some of the anatomy that you may have forgotten. There are three bones in the finger. There's the distal phalanx, middle phalanx, and proximal phalanx, and these articulate with the metacarpals. In the thumb, you've only got two bones. You've got distal phalanx and proximal phalanx, and this metacarpal links with the trapezium, which is the commonest site of osteoarthritis in the body. The joints we use, you may see in letters and things from consultants, DIP joint, so that's distal interphalangeal joint, that's the joint right at the tip. The PIP joint is proximal interphalangeal joint, and then the MCP joint, and that's the when you make a fist, these are these knuckles here. Down here, we refer to the CMC joint, which is at the base of the thumb, and that's the first metacarpal articulating with the trapezium, so that's the CMC joint, osteoarthritis. I'm going to talk about the flexor tendons. There's two flexor tendons in each finger. There's a flexor digitorum profundus, which is the deep tendon, and that inserts into the distal phalanx. Superficial to that is the flexor digitorum superficialis, and that's shaped like a Y, and it wraps round at the chiasm in the mid finger. What nobody tells you in medical school is this structure. And these are the pulleys of the finger. They're very, very important, cause a lot of problems. I don't think anyone ever taught me at medical school about that, and certainly we'll talk about it later. In the hand, the ulnar side is 1.5 digits, and that's supplied by the ulnar nerve, and on the radial side is the median nerve, and that's 3.5 digits. And each finger has a radial digital nerve and an ulnar digital nerve running down it. So when you're examining, the best thing, just look at the hand, look at the front, look at the back, look for any masses like this. This is a mucocyst. Any muscle wasting you may see, that's ulnar nerve palsy. You get wasting of the first dorsal interosseous. Any scars, either from an accident or previous surgery. Any contractures or finger in an unusual position. When you're feeling a hand, the bit you want to concentrate on is this area around here. That's where most of the trouble's likely to be. And what you're looking for is hidden lumps that you can't see. So, very common site of a ganglion at the base of the finger. Tumours, the commonest tumour is a thing called a giant cell tumour of the tendon sheath. That's likely to be in this area. Trigger finger, you can feel the thickened A1 pulley and tendon. And you can pick up early Dupuytron. So if you're going to look at someone's hand, concentrate on this red box. And lastly, you want to divide the finger down the middle and feel for the ulnar digital nerve and the radial digital nerve on each side to check it's intact. Movement, I just check the flexor tendons, just FDP and FDS tendons. So checking FDP is the easiest. You just get them to flex the distal phalanx. Checking FDS in each finger is slightly more complicated because of the FDP tendon has a common muscle belly, and we call this the quadriga effect, named after the Roman chariot with the 4 horses. So you have to neutralize the FDP tendons and then check each FDS independently. And then you can do specific tests. You could do a grind test, which I'll cover, and a Finklestein's test. So I'm going to run through some of the common hand problems, tenosynovitis and trigger finger. ganglions, Dupuytren's disease, carpal tunnel syndrome, and then arthritis at the base of the thumb. So we'll just take these one at a time. What's happening in trigger finger is basically the A1 pulley here is too tight, and the flexor tendon is jamming against it and setting up an inflammatory response, and that becomes painful. So the number of pulleys, there are A pulleys and C pulleys, but basically the problematic one is the A1 pulley, and that is about there on surface anatomy. It's overlying your metacarpal head. And the reason for these pulleys is that when you contract the fingers, it's much more efficient. It's a mechanical device. It stops them bowstringing. I usually use Adcortal, which is triamcinolone in suspension. It lasts about 3 months, and it does take about a week to kick in, so do be patient. Injecting of trigger fingers. BMI run a number of workshops to reinforce this. I get a 2 ml syringe, an orange needle, and I stick the needle actually right into the tendon. I then get them to flex the finger forward, and the syringe will go the other way. So you get what's called paradoxical swing. That means you're actually in the tendon. You then start pressing, and you won't get any fluid in because you're in the tendon. And as you pull back, you come out of the tendon and into the sheath, and suddenly it gives, and you put all your steroid into the sheath. You can get trigger thumb in an adult. That's completely identical to trigger finger. What you've got to be aware of is triggering in children. It's a completely different process, and you don't want to be injecting steroid. If you see a child with a trigger digit, they need surgery. Okay, so tenosynovitis is at the wrist. It's called de Quervain's tenosynovitis. It's commonly on the radial side, and it's the two tendons here. It's extensor pollicis brevis and abductor pollicis longus that are just about there. And they become trapped under the extensor retinaculum and set up an inflammatory process. The test for that is called Finklestein's test. It's very easy. You just get the patient to make a fist, incorporate the thumb, and then you flex it. And if they've got it, they'll hit the roof. It's very, very painful, but very diagnostic. You can inject this with steroids. Somebody's done some nice surface anatomy. The two tendons we're interested in are these two tendons, and you just inject some of the steroid around those tendons. You don't need to be so accurate. That's often accompanied by a resting splint for 6 weeks, and then see the patient back. If they haven't responded to steroid injection, they're going to need surgery, and that can be done under local anaesthetic or general anaesthetic. And you simply are releasing the extensor retinaculum that's too tight and freeing up the tendons, and that surgery is curative. So when would you want to refer for tenosynovitis? Really when it's painful. Somebody, whether it's a GP or a hand surgeon or somebody doing ultrasound, has injected steroids. As long as somebody's put some steroid in, ultrasound can be very useful and very accurate. You want to wait 6 weeks, and if that's not settled down, you need to see a hand surgeon. So I've just got one case scenario for this. I've got a 45-year-old lady who presents with a ring finger that's actually locked in flexion. She can't actually move it. And prior to that, it's been clicking for months. And this is slightly different. This is tenosynovitis that's become triggering and then gone on to locked finger, and that's actually a surgical emergency. She needs an operation in the next week to release the A1 pulley down here and free up the finger. So sometimes they get so bad they actually lock. Okay, ganglions. Very easily diagnosed on either ultrasound or MRI. Commonest site is on the dorsum of the wrist. That's the classic, but there are many other places we see them. Around the DIP joint, we call a mucus cyst. often at the base of the finger, on the volar aspect. That feels like a hard P. You can get a large volar ganglion around the radial artery. That's quite common. Nobody really knows what a ganglion is. It's a degenerative hernia is probably the best way to think of it, of a lining of the joint. And the key thing is it's under pressure. So when you feel them, they're very hard. They feel like bone sometimes. The stuff in them isn't fluid. It's actually gelatin. So to try and aspirate it can be very difficult. And if you are going to aspirate it, I would actually put some local anaesthetic in. Get a big needle, white needle or bigger, and a big syringe, a 20 ml syringe. Don't muck about with a 5 ml syringe and an orange needle. It simply won't work. Unfortunately, aspiration is quite common, unsuccessful, so 50% of those patients will come back with a recurrence. If they do and they want surgery, the key thing about surgery is you've got to get down and take out the stalk of the ganglion, otherwise you risk recurrence. And that is arising from the scapholunate joint, and it's quite difficult to get there under local anaesthetic, and most people would do them under general anaesthetic. So when to refer for ganglions, I would refer when they're painful, repeated rupture, or unsuccessful aspiration. This is a common thing I see in my practice. Is a 70-year-old lady with osteoarthritis. She's got this lump on her thumb. It's very painful when she knocks it. She's stuck a sewing needle in it several times and squeezed fluid out, but it keeps coming back. And what's going on here is that she's got a mucus cyst. It's common with arthritis-affected joints, and the pressure from the ganglion is pressing on the nail bed and causing grooving in the nail. And the treatment for that really is local anaesthetic, ring block of the finger, and surgery to remove that ganglion. At the same time, you also want to take away the osteophytes from the osteoarthritis that are there. It reduces the recurrence rate. Okay, carpal tunnel, I'm sure everyone's familiar with this. The classic features are usually ladies in their sort of 40s or 60s, the radial 3.5 digits, night waking and numbness. Now, unfortunately, most people don't fall into this pattern. It can occur at any age. You can see it in men. Often they have a vague numbness or ache that they have difficulty articulating. Forearm pain is actually extremely common. If you ask a patient who's got carpal tunnel, that often they do have forearm pain. They may say that they're clumsy, and you can certainly just have 1 or 2 fingers affected rather than the classic 3.5. Very simple test to do in clinic is Tinel's test. You simply tap the wrist over the median nerve, and you'll elicit the symptoms in the fingers. Or Fallon's test, you ask the patient to adopt that posture for a minute, and that should set off the symptoms as well. Now, nerve conduction studies I would consider essential in managing carpal tunnel. What happens is they have an electrode, and you fire an impulse backwards across the carpal tunnel and collect it in these recording electrodes. You get a whole jumble of numbers that don't mean very much, very confusing, but what you're looking for is reduced speed of conduction and loss of amplitude, which means there's axon damage. And what's going on in carpal tunnel is because of the pressure, the patient undergoes ischemia of the nerve with demyelination of the nerve, and then that's when the symptoms start to develop. The treatment, first line would be splinting. Many patients respond to steroid injection. I don't do much steroid injection. I tend to operate. And that's when you're releasing the transverse carpal ligament. You're simply dividing this ligament and releasing the pressure. It takes 20 minutes. You can do it under local anaesthetic. It's very straightforward. You just go through the skin, find the ligament, you just divide it and stitch it up. It's not that difficult. What is more common is failure after surgery. and that's because you've probably got the wrong diagnosis, or if they do have true carpal tunnel, patients who are older do worse, patients with long-standing symptoms do worse, patients with the nerve severely compressed do worse, and diabetic patients don't recover. So whenever I see somebody in clinic with any of these problems, I always warn them that after the surgery they're not going to do as well as somebody who's 20 years old and had it for 2 months. You may send a patient you think has carpal tunnel for nerve conduction and they come back normal. You must think about the neck, whether they've got some disc or some degenerative change in the neck. They need an MRI scan, basically. So when to refer carpal tunnel, I would say constant symptoms, not resolved with a splint or a steroid injection. And before you operate, or anyone operates, I would consider it now medically negligent that you don't have nerve conduction studies. And no matter how good Rumpole is in the Bailey, you're going to be in trouble, I think, operating on somebody with carpal tunnel without nerve conduction. I've got one sort of relevant case scenario you may come across is a sort of 35-year-old lady who works in the city. She has her BlackBerry phone, she's on it all day. GP has been to talk, sends her for nerve conduction, which is normal. MRI is also normal, but she's got these pins and needles in her hands. She probably has what we used to call repetitive strain syndrome or repetitive strain injury. We now call it work-related upper limb disorder, but it's the same thing. It relates to poor posture, and the cure for that is physiotherapy and re-education. But that's extremely common with these iPhones and iPads and things. I see it a lot more in my practice. Okay, second last, got Dupuytren's disease. This is a fibromatosis, or excess fibrous tissue, about 1 in 20 of the population, and usually presents with lumps in the palm. These can also cause bent fingers due to cords, and it's usually the ring and little fingers. We know there's a strong genetic link. You only really see it in Caucasian people, and it's thought to be originated in the Vikings. And the Vikings were great travellers. They went to America before Columbus. They went throughout Europe, so you will see it in basically North European people. What's going on in Dupuytren's disease? In the normal anatomy, you have a layer of fibrous tissue, which we call the palmar fascia. Everyone has it. For some reason, that thickens. And that thickened fascia shortens, and when it starts shortening, that's when the problems arise. And the problem is it wraps the nerves. This makes operating on it quite difficult because, like concrete, and all the nerves and vessels are encased in it. There are a number of treatments for Dupuytren's. The best treatment, or the gold standard treatment, would be a fasciectomy. And that's an operation under general anaesthetic where you open the finger up and simply cut out the fibrous tissue. That has the lowest recurrence rate. There's two other things you may hear about is a thing called a needle fasciotomy, and that's simply dividing the fibrous tissue with a needle, usually under local anaesthetic, high recurrence rate. And recently, in the last couple of years, there's an injection called collagenase. It's marketed by Pfizer called Xiapex. You inject under the skin and that will dissolve the collagen. Unfortunately, it looks like there's quite high recurrence rate with that as well, and it's not proven yet. So, when to refer Dupuytren's disease? If you've got mild Dupuytren's, you don't need to see a hand surgeon. The patients I would recommend you send to see a hand surgeon are those with painful palmar nodules. That's actually quite rare. MCP joint of 30 degrees is probably best remembered. If the patient can't put their hand flat on a table, they should probably see somebody. But more importantly, I say any PIP joint contracture. So if you've got, this is the PIP, any involvement of that joint with Dupuytren's, most hand surgeons would want to see the patient. My experience is most patients with Dupuytren's come to see me too late. So I've got a 60-year-old man who's a joiner. He's got Dupuytren's disease. It affects both his hands. especially his finger. His father had a problem and has his finger amputated, and he's obviously very nervous about surgery. He's been reading the health section in the Daily Mail, and he's seen something about an injection, and he wants that. Well, he's not going to get an injection. He needs an operation because the PIP joint involvement will do much better with surgery. The recurrence rate at the PIP joint from the injections is something like 60%, so he'd be much better off having a true fasciectomy. Okay, last topic. Osteoarthritis of the base of the thumb. Very, very common. Usually postmenopausal ladies. It can be extremely painful, and they have great difficulty with grip, particularly of the thumb, and they tend to drop objects, often kettles, and they get very worried about lifting things in the kitchen that are hot. The treatment initially is non-steroidals and a resting splint. You can inject the joint. It is difficult because the joint space has narrowed down with the arthritis, and it can be very difficult to get your needle into the right place. They do respond to steroids, but it only lasts 3 months, and they can keep coming back to your clinic, and that's really not the answer. The answer to this problem is a trapeziectomy. So you make an incision on the hand, back of the wrist, take out this bone that's like an elongated dice, and on the x-ray you can see the missing bone. The thumb functions extremely well, but because there's no bone rubbing on bone, they tend to be pain-free. So if you've got somebody with arthritis at the base of the thumb, and they've failed splinting, and they've tried Voltarol unsuccessfully, and they've got pain that's driving them crazy, they'd benefit from a trapeziectomy. Now, I haven't mentioned this before, but a very useful test in clinic is a thing called the grind test. So you take the patient's thumb and you telescope it into the wrist and start rotating it. And you can actually feel the bone grinding on the trapezium, and it will set off the symptoms. But it's classic for, it's diagnostic for osteoarthritis at the base of the thumb. Because she's having intermittent pain, I would suggest that she has Voltarol and a hand therapy custom-made splint. Often that will settle things down and stop a trapeziectomy being required. On the subject of splints, I would just like to say we have a fantastic range of hand therapists who can make quite elaborate and custom-made splints for a variety of hand conditions. I certainly can't perform any hand surgery without the help of the hand therapists, and we have them at all the BMI sites. Thank you.
Okay. Thank you, Neil. So, have we got some questions around? Yes.
Somewhere in the back of my mind for carpal or suspected carpal tunnel, I always do thyroid function tests before I refer. Is that worthwhile, or have I just got stuck in a rut and I should do some more evidence-based medicine?
It's not a bad idea. To be honest, somebody's usually done them before I see them, but I think it's a very reasonable thing to do if you seriously consider that. Yes, I think that is a good thing to do. And if you're clinically suspicious, yes. Yeah.
Again, 2 quick questions.
1 second.
So you mentioned giant cell tumour at the start.
Yes.
I don't know much about that. I'm just worried about differentiating that between a trigger finger in terms of having a nodule. Do we need to scan all nodules there for a giant cell tumour? How common are they? And the second question quickly is, do we need to do a nerve conduction study before we inject for carpal tunnel, or can we just get on and inject first?
You can just get on and inject, I think, would be great. But if you're having surgery, I would definitely have a nerve conduction study. When you've got a lump in the hand, the commonest 2 lumps in the hand will be a ganglion. The ganglion will be the most common. An ultrasound will pick that up because it can tell the difference between cystic and solid. So if I'm going to leave a lump in the hand, I will get an ultrasound. Most lumps in the hand, I actually won't bother with any imaging. I'll just operate because I'm going to take it out and send it to pathology. My experience of ultrasound in the hand for other conditions is extremely unreliable. I would completely agree with some of the other consultants who've talked, but ultrasound not good in the hand, but very good for cystic versus solid. So a giant cell tumour of the hand is a solid lump like a ganglion. It's rare, never kills you, just spreads a bit. So if you're thinking of leaving a lump, then I would ultrasound them.
I've got a musician who has OA of the base of the thumb.
Please don't send them to me.
Sorry?
Please don't send them to me.
So you can't guarantee that she's still going to be a good musician after her trapeziectomy?
Yes, musicians are a problem for hand surgeons because their career depends upon it, and I think you need to spend a bit of time counselling. They should function very well if you do it correctly. The operation, everything goes well, they should be fine. It depends how bad the pain is. If the pain is incapacitating, then you want to do a trapeziectomy. And I often put the ball back into the patient's court and say, look, if you can't play the instruments and what you want to do, then you really should consider trapeziectomy. But if they're just moaning a bit, I really try and encourage them to have a splint and Voltron, because I really want to avoid operating on professional musicians as much as possible.
Thank you. My question's about wrist splints. Custom-made wrist splints sound fabulous. We have a lot of trouble getting any kind of device really on the NHS in my local area. And so I'm sometimes saying to patients, perhaps you can go to a larger pharmacy and try and buy yourself a wrist splint.
Yes.
Am I right in thinking that for carpal tunnel that needs to be a rigid wrist splint, and does it need to be worn day and night? And also, these things aren't prescribable either. Is there any good source of these kind of splints online or something that perhaps you could recommend?
The problems with splints, often the over-the-shelf ones aren't very good. They've often got a bit of metal in here, which is the last thing you want. I am lucky in both NHS and private. I have hand therapists, and I send the patient to go and see the hand therapist. They'll make a fantastic splint. You can refer directly to a hand therapist privately, but if you in NHS, you'd have to go through a hand surgeon.
Yes, and of course we're being encouraged to work people up and do all the conservative stuff before we refer. Tremendous pressure on us not to refer.
Yeah.
So is there any sort of ways of obviating referral by getting us to be able to have access to these things first? I suppose commissioning might help with some of this with the
Yes, it's
The question there, if you couldn't hear over there, is actually about accessing these services, needs to go through the hand surgeon, which doesn't help us if we're working patients up.
Well, it's very difficult. Privately, it's easy. You can just refer straight to the hand therapist. NHS, much more difficult. That access has always traditionally been through a hand surgeon. That may change in the next few months. I don't know.
A challenge, I feel, for the commissioners. Okay.
Have you seen recently kids using this mobile phones and excessive use of mouse causing such kind of injuries?
It's usually people in their 30s and 40s who spend all day on keyboards. It's usually not kids. It's not kids playing games. It's usually middle-aged adults. BlackBerry is particularly bad. The people sort of sit like this. But poor posture. Anyone who's got an office-based job, I ask them, how long do you spend on the computer? And some of them will say 10 or 12 hours. And they've got normal nerve conduction studies, and then the penny drops, you know, what's going on. And they do very well.
Okay, just a question from here, which is about joint replacements. And we get a lot of patients with really very severe degenerative interphalangeal joint disease. What's your kind of position on that?
Yes, I do a lot of joint replacements for osteoarthritis in the hand. I do a lot of what's called Swansons. The shift has gone from very complex joint replacements back to one that was in the 60s, so it's just a plastic spacer. Yes, good operation.
And when should we be, and who shouldn't we be referring, and who should we be referring?
Well, most hand surgeons would be able to do that.
But in terms of who the patients that we should be referring,
intractable pain that's not responding to non-steroidals, then a joint replacement will get guaranteed to get rid of the pain. Very good operation for pain. How much movement they get is how compliant they are with the hand therapist afterwards, but very successful operation, particularly for individual joints that are causing problems.
Anyone who we particularly shouldn't refer, in other words, who doesn't do well with surgery?
No, they all do quite well.
Very good. Last question.
Just basically asking that Voltral you're recommending, is it for the local, for the arthritis of the thumb? Like for the knee, we use local Voltral gel.
Oh, the Voltral gel.
Yeah.
Yes, that's good. That's a good idea. Yes, I sometimes get patients to do that.
Is that evidence-based?
No, of course not.
Sorry. Okay, all right.